Well, thank you all for staying. I really do want to thank Lenny for bringing us all together. Sorry I missed part of this meeting, but I hope to provide some perspective on what I think was talked about during this meeting and what I know was talked about today during this meeting, and where we're going to go with young adults with ALL. So, about 14 years ago, my work in this area began when I did a retrospective comparison study with a number of colleagues, both in the CCG, COG, and the CALGB, to look at the outcome of young adults with ALL. And what we found began my next 14 years of work, which was to really focus on this age group once I found out that the outcome of these patients, who are ages 16 to 20, was dramatically different if they were treated by an adult oncologist versus a pediatric oncologist on a clinical trial. And once I presented these data, they were corroborated all over the world, really. And that really stimulated all of us who are here today to try to make some major improvements. And we've heard a lot today about, and over the last 2 days, I'm sure, about what could account for these differences. And we know now that it's all of these things. It's the treatment, it's the disease biology, it's the people, the patients and the physicians who treat them. And they're all very subtly important, and we've been trying to focus on how to make things better in all of these aspects. So you know now that we used those data to develop a prospective trial that was done in the U.S. intergroup, which was completed 2 years ago this month. It was 10403. We extended it to through age 39, and that was really because the NCI had defined AYA cancers as through the age of 39, and also interestingly because in our data set in the CALGB, the outcomes of the 16 to 20-year-olds and the 20 to 39-year-olds were identical. So we thought this is a group where we could probably apply a different treatment approach, that people would be hardy enough to tolerate a pediatric regimen, and that's what we did. And this was the 10403 trial. You've probably seen this slide earlier in the meeting. It really is nothing unique. It really is one arm of the COG 0232 trial. That was the standard risk arm with the Capezi methotrexate. So the study was completed between 2011 and 2007 and 2012. 318 patients were entered. You can see the demographics of the patients. Importantly, the median age was 25 years. The majority of patients on this trial were between the ages of 20 to 29 years of age. And you've seen these slides, I'm sure, from both Anjali and from Matt Wiedewelt, but I just want to emphasize one particular thing, that we actually did just fine overall with this study, and that our induction mortality and our overall mortality rate was no different than the pediatric study, and we had 2% induction mortality. But yes, there are some big differences. And the big differences do have to do in part with toxicity, particularly toxicity during induction therapy. And that particular toxicity is largely, I believe, asparaginase and steroid related. We had much higher rates of liver toxicity, and we had higher rates of febrile neutropenia during this study, I think partially because we encouraged patients to remain in the hospital during this month, and we might have picked it up a lot more frequently than in the 0232 trial, but I don't know that. By Toxicity Summary, Anjali probably talked a bit about this. By age cohort, osteonecrosis, mucositis, and neuropathy were all higher for patients over the age of 20. But overall, the comparison toxicities, as I said, despite the higher rates of hepatic toxicity during induction, the other high toxicities to the liver were similar throughout the rest of the treatment. There were similar rates of pancreatitis and osteonecrosis. There were higher rates of thrombosis in our adult population, and lower rates, as you've heard already, of hypersensitivity, largely because we premedicated patients once we had this incredibly high rate of hypersensitivity of up to 25% in our first group of patients, and we decided we would premedicate, and we lowered that dramatically. And we don't believe that silent inactivation of asparaginase is a big issue, although, again, we don't know that for sure in this population. Again, we were very pleased that our treatment-related mortality was very low. This is a study that was done all over the United States in many, many centers, 3% mortality. I'm going to give you a little synopsis of the outcome. These are data that will be presented at the ASH meeting in great detail, so I can only present a little bit of the data today. But basically, we're very excited that these data suggest that using an intensive pediatric regimen in the large cooperative group setting in the United States is feasible. We were able to work as a cooperative community and accrue on schedule. And importantly, our event-free survival estimated at 2 years is 66%, with 78% overall survival, which of course to me is thrilling because it's a very significant improvement in comparison to our 39% survival for young adults with this disease on our prior CA-LGB regimens. And also of importance, this is the data that was published by my friend and colleague, Jim Nachman, a number of years ago, of the young adults, actually 16 to 21 years old only, who were entered onto the 1961, which was the 0232 predecessor study, and we achieved very similar outcomes to the pediatricians who treated these patients in that study. So I bring Jim's picture up here. Jim was a wonderful, important figure in the world of pediatric oncology, and he was a truly wonderful colleague. He helped to stimulate this work, and he always told me that pediatricians knew better how to treat ALL, and I have to say that he's probably right, but we do have some insights of our own, and we do have some special challenges of our own in the adult population. And I know you've seen some of these data as well. They're extremely provocative data. I always suspected that there was a subtle change in biology as patients age, even from 16 to 30. And in fact, that's being borne out now by these fascinating data that were presented over the last couple of years, largely led by Charles Mulligan and colleagues at St. Jude, but a worldwide effort. And it shows really that young adults with ALL are different. They have higher risk disease, and you can see that the incidence of the pH-like signature in these patients is up to 27%. So these are higher risk patients. This is from their New England Journal paper that was published just 2 weeks or 3 weeks ago now, showing that, in fact, you can see on the lower curve there, the young adults with the pH-like signature really do poorly. And so we have a specific challenge in this age group. We've improved survival a lot, but we have a long way to go, and part of it has to do with trying to target this bad disease biology. So we've looked a little bit at our 10403 patients. I sent samples from about 110 of the 300 patients who were entered onto 10403 to Cheryl Willman's lab at the University of New Mexico to look specifically at the outcome of the 10403 patients by the signature as defined by this low-density array card that they use now to identify the signature. And you can see that there is quite a big difference here, that the patients who have high-risk disease, the red line here, have only a 52% 2-year disease-free survival. In contrast, the survival is exceptionally good for those without the signature, which is only 20% of the patients in this cohort had the signature, and the rest who didn't had an 89% disease-free survival. We also show, importantly, that minimal residual disease detection, and in this case, we did MRD analysis using real-time PCR for the IGH rearrangements, and we found that patients who were MRD negative, that is, absence of detectable MRD with an assay that's sensitive about 1 in 10,000 to 1 in 100,000, at day 29, there were no relapses. There have been no relapses to date. So that's an exceptionally powerful prognosticator of outcome here. It's a small subset of patients that we were able to study, but I think this is very relevant. Importantly, only a third of our patients are MRD negative at day 29, so that's another challenge. So how are we going to take all of this important information and exciting new information and go forward? So what have we learned? Well, for once, we've learned that the cooperative groups in the United States can actually cooperate, and I think that that's really critical for moving forward towards personalizing therapy for a disease as rare as ALL and a disease as heterogeneous as we're learning as ALL, and that using a pediatric regimen is beneficial, that the toxicity profile is different, and I think in particular, and I know you heard about this earlier in the meeting, that we need to understand how to optimize the asparaginase use in young adults with ALL. I think this is a very fascinating area, and I'm going to just mention a couple thoughts about it in a few minutes. The disease biology is clearly different. MRD status is very important. And finally, it does take a village. It takes a world, as I've heard from the talks earlier today, to make things better for our young adults with ALL. So how are we going to do this? Well, I think asparaginase, as we all believe, I think, many of us anyway, believe that asparaginase is an important drug for helping to cure ALL. And we have to make pegylated asparaginase in the United States work for us because it's currently the only approved form of asparaginase other than Erwinia, which of course is used for patients with intolerable hypersensitivity. The metabolism of asparaginase with steroid particularly changes with age. We understand very little about that. We know that the metabolism changes. Mary Relling has presented very interesting data of the change in metabolism that occurs in the early teenage years, but little to nothing is known about older teenagers, young adults, or older adults. We don't know about the role of obesity. In our 10403 study, 29% of our patients had a BMI over 30. It's pretty shocking, but that's what the numbers are. And we're beginning to try to tease that out as well. So what can we do about this? There's an asparaginase assay that's now readily available. It's commercially available. It's easy to send. It's easy to get a result quickly. And it may help us to address the concern for overdosing of asparaginase in this population. And we'll also be able to detect silent inactivation if it occurs. And lower dosing may still result in adequate and prolonged exposure and decrease the toxicity. And just anecdotally, over the last couple of months, in my treatment of all patients with ALL who are getting asparaginase, I've been sending these assays, and it's quite revealing because even using very much lower doses of asparaginase is probably going to result in very, very adequate asparaginase levels and probably reduced toxicities. Then there's the question of pulsing dexamethasone rather than the 28-day straight schedule. Many of us feel that that might be better tolerated by this young adult population. What about the disease biology? Well, we know that pH-like ALL is bad. We know that pH-like ALL is quite common in this population. We know that MRD is very bad, and MRD following induction is very common in this population. And I showed you that if you don't have MRD, you do fantastically well. So what agents can we use to eradicate MRD, and which may also be effective for pH-like ALL? Well, the antibody conjugates, about which you've heard a lot, the bispecific antibodies, perhaps the CAR T cells in the future, and targeted kinase inhibitors. So some of the thoughts that we are trying to incorporate into our planning include how to identify these very high-risk patients early on. I don't know if you saw this slide earlier in the meeting, but there are methods that are being developed, including assays that are trying to be patented, to help to quickly identify the pH-like signature in patients with ALL. This is from the Willman group, and it shows event-free and overall survival using this LDA card, which is a very quick and easy method that they've used, an 8-gene or 15-gene panel that they can use to quickly identify the high-risk signature. And it shows just that they were able to do this in the pediatric group, and then they validated it using this assay. And my hope is that you can see on the left the MRD slide from our 10403 study, that we're going to be able to incorporate both MRD and the high-risk pH-like signature into the early prognostication and stratification of treatments treatment of patients as we move forward. And for example, the COG has done this, and they show very, very nice sort of splaying out of outcomes based on the presence or absence of these two parameters. So the idea that we had, and that Lenny asked me about earlier, and that we'd had complete buy-in from the NCI, we'd even gotten a lot of additional funding from NCI for this study, and we'd been working with the pharmaceutical company for the last several years to design the successor study. Our idea was to try to eradicate MRD by introducing a novel agent early into therapy. And the agent we had chosen was inotuzumab because of its high response rate in relapsed disease. It's fairly easy to administer, and we'd had a lot of experience. Many members of our group had had experience with the drug in the early phase trials and felt very confident about trying to incorporate it early into therapy. So this was going to be our trial, and it was supposed to open actually this week. About 2 months ago, as you heard mentioned, we got word that for reasons that we're still not sure of, and it is not a toxicity issue, we were told that for sure, so it's some sort of a business decision that the pharmaceutical company does not at the moment want to support this trial. So rather than crying, which I actually probably did do for a few days, we've been trying to re-strategize and think about what else we might do if this doesn't come forward. And one of the things that we were going to do anyway was stratify patients on the basis of the pH-like signature, so we're still planning to do that. And we're thinking now about perhaps a different antibody, trying to incorporate a different antibody into frontline treatment, and then also stratify on the basis of the pH-like signature and whether or not there's a targetable kinase that we can target. And so this is in the very early stages of development. We're just thinking about it. This is going to be a statistical challenge because the number of patients is small, the heterogeneity is great, but we're beginning to have discussions with our group statistician, and this study is going to be led by Dan D'Angelo for the U.S. Cooperative Groups, and I know you heard earlier in the week from Dan. So will it be useful to target MRD with a TKI in a pH-like patient? And I'm just going to give you an example, a very interesting example of one of my own patients in whom we were able to identify the pH-like signature. I have a very talented colleague, Gordana Raka, who's one of our cytogeneticists. She's been doing CGH arrays on our ALL patients, and she's been able to identify the pH-like signature or specific pH-like activated kinase fusions using this CGH array. And this didn't come out particularly well, but this is a CGH array of one of our patients. This is an 18-year-old woman who was induced according to the 10403 regimen just a couple of months ago. She had a normal FISH panel. She had a deletion on chromosome 5 by cytogenetics, you can see there. And actually that deletion resulted, it's a microdeletion, and it resulted in fusion of EBF1 with PDGFR-beta. And you all know that PDGFR-beta is susceptible to targeting with a tyrosine kinase. So this young woman underwent induction therapy. I'm going to show you her day 29 marrow post-induction is that marrow on the left. Her marrow was packed with leukemia at day 29, which, you know, we rarely see in even in adult ALL, we don't see that. We We continued consolidation therapy. We added dasatinib, and you can see 6 weeks later, we added imatinib in this patient, dasatinib in a different patient of ours. Post-imatinib, she had absolutely no evidence of disease, and she has now gone on. She's actually undergoing allogeneic transplant at this moment. This just shows, again, this is the aspirate of the same marrow. Aspirate before and after TKI treatment. So it is possible that these TKIs, and you've heard case reports and you've seen some things in the literature, that we will be able to identify these patients, we will be able to target, and we will be able to add these agents, I think, to our standard therapies. But there will be some challenges. We have to personalize the therapy, and genetically directed therapies are going to be difficult. We have to really validate the screening methods. We have to test these targeted agents in a very rare subset of patients. And it's going to be hard because we have to cooperate to do that, and it's going to be a worldwide effort, I think, to really try to get at the answers to these challenges. This is a tremendous opportunity, and as I said, we're going to have to work together to answer these questions. And I think it's going to be really important that we have a standardized platform on which to build these targeted therapies. And I think that adult and pediatric participation, if we design the right platform, might be possible. The other thing about it taking a village, well, you heard a lot this afternoon from people all over the world who are faced with the challenge of treating young adults with ALL. It's no different on the south side of Chicago. It's a tough group of patients to treat. They have many unique challenges. And in my neighborhood, they're very socioeconomically challenged. And so many of my patients don't even have bus fare to get back and forth to clinic. So what we've done at our institution is we've created a young adult clinic, and it's really a joint effort of our pediatricians and the adult oncologists in our center. We're fortunate in that our centers are together, and we actually have this clinic in the Children's Hospital. It's composed of both pediatric and adult oncologists. This is our little group from a couple of months ago. It includes pediatric hematologists, a survivorship person, social workers, a psychotherapist, a physical therapist, and it's really a wonderful model, I think, for us for care of these very highly challenged and challenging young adults with cancer. And we're trying to integrate the psychosocial care with the state-of-the-art therapy. It's also a really interesting basis for some clinical research. A couple of the initiatives, this is one of my young adult patients with his wife and 2 children, and we have a really lovely playroom, which is really for the children with cancer, but our patients' children can also use this area and have really enjoyed it. So one of our former fellows, Lori Muffley, who's now an assistant professor at Stanford, performed a really nice study of post-traumatic stress in young adult patients in this clinic who had completed treatment for malignancies. She's writing up these data now, and hopefully they'll be published. She presented this last year at ASH. Tara Henderson, who's a pediatrician, a colleague of mine also who was in that picture, has a study of risky behaviors in young adults receiving treatment. And we're also piloting tools in this clinic for assessment of the alliance between patient and caregiver and treatment compliance, which we had incorporated into our study that we were hoping to start this week, and that will incorporate into future studies, we hope. And I'd just like to close with a photograph of one of the first patients who I treated on 10403. She's the bride. She's in the middle there. She wanted me to make sure that I pointed out her portacath site, which is gone, but she wanted me to show her scar. And she got married a couple of months ago and is now about 4 years out from completion of treatment on 10403. And so, of course, this is what we all live for. All of us in this room are working together to hopefully improve the outcomes and the survival and the quality of life of our young adults. And with that, I'll close and just acknowledge all of my colleagues at U of C and from around the country. Thank you very much. And thank you, Lenny.